infectious disease endemic in our country, and it is caused by Salmonella typhi, Paratyphi A, B, and C. So it is commonly called as typhoid fever, but you know, typhoid fever it is called when it is caused by Salmonella typhi. So enteric fever can also be caused by paratyphoid A, B, C. So you cannot combine both of these in typhoid fever. So it does not completely mimic the enteric fever. So it should be clear. Then when typhoid fever is caused by Salmonella typhi, so it is called as typhoid fever. And when enteric fever is caused by Paratyphi A, B, and C, then it is called as enteric fever. It is gram-negative rot. So it is very important to know its bacteriological structure as well as gram staining, because when you advise a patient with suspected enteric fever, so you have to confirm that organism on microscope as well as on cultures. So if you know how it looks like, then you can identify it on your microscope. So it is a gram-negative rot. Its structure is very important. It is covered by a capsule, which is a virulence factor for its survival, and its mutations in different parts, especially in capsular antigen, is very important to be a drug resistant. So it looks like under microscope like this. And when you gram stain, the Salmonella typhi look like red stand, and they are rods. And on immunofluorescence, you can see how their flagella are look like. So you cannot appreciate these type of flagella simply on the gram staining. You have to need a specialized microscope to look for it. So in developing countries, it affects about 100 to 1000 cases per 1 million population. The important thing is the drug resistance, which is very difficult situation nowadays, and the drug resistance is especially to all three primary antimicrobials. So the spread of this infection occurs with direct or indirect contact with infected person. That means that only humans are the source of transmission, especially for Salmonella typhi and Paratyphi A. Ingestion of foods or water which are contaminated with Salmonella typhi from human feces is the most common mode of transmission. So in this regard, our sanitary condition plays a very important role in the transmission of the organism. So we briefly look in the pathogenesis of enteric fever. As I have already mentioned that humans are the only reservoir for Salmonella typhi and Salmonella Paratyphi A. Salmonella Paratyphi B and C, they also infect dogs, cattle and poultry, and they can be transmitted by the eggs or poorly cooked meat. So Feco-Oral Route is the most common route of transmission, and less commonly the urine of infected person may be the cause of transmission. And the dose, infectious dose, is 10 raised to power 5 to 10 raised to power 9 organisms. The incubation period for this disease is 7 to 14 days, but this is the usual incubation period. But it can be from 3 to 30 days, depending upon the infecting dose. So this is very important slide. We have to see the sequence of events which occurs during the course of illness. First of all, when a person ingests contaminated food or water contaminated with Salmonella typhi organism, so it reaches from our mouths till terminal ileum, where it invades the gut mucosa, and through the specialized antigen sampling cells, they are called as M cells, within the pair patches in the terminal ileum. It is Salmonella typhi is phagocytosed by the macrophages. These macrophages then enter the mesenteric lymphoid system and then passes into the bloodstream via the lymphatics. So this is the main route of entrance into the bloodstream. Here the primary bacteremia start, and then these bacteria are disseminated throughout the body. So wherever they colonize the organ of body, the symptoms will depend on that involved organ. So they involve especially the reticuloendothelial system, in which the patient will have a hepatosplenomegaly. So they replicate within the macrophages and they shed back into the blood. So when first in the primary bacteremia, they disseminated throughout the body and they colonize especially the organs of the reticuloendothelial system, and from that reticuloendothelial system they again enter into the blood, and that at that time they are causing secondary bacteremia. So this is very important, that secondary bacteremia, if occurs, the symptoms are started to develop in the patient. As we have discussed, the virulence factor is a capsular antigen which interfere with the phagocytosis, and a virulence state encoded by the phop regulon, which gives ability to survive within the macrophage. So the survival of the Salmonella typhi will be increased after the this capsular antigen which is found in the Salmonella typhi. So it avoids triggering of an early inflammatory response in the gut, and instead colonize deeper tissues or the organ systems and produce inflammatory response in the deeper mucosal layers and underlying lymphoid tissue, which causes the hyperplasia of the pair patches and subsequent necrosis and sloughing of the overlying epithelium. And when you come to know the pathogenesis, then it will be easier to interpret the clinical signs, symptoms in the patient, because when the disease involving the multiple system of the body, then it will be difficult to interpret the different causes of the illness. So we have to be clear in the pathogenesis, how the Salmonella typhi enter in our body, from where it goes to where. So these all are very important. So these ulcers in the gut, they can be bleached, but they can be healed without scarring or structure formation. Inflammatory response or inflammatory lesion may occasionally penetrate the muscularis layer of the gut, and as well as the serosa of the intestine. When they perforate, then when they penetrate these two layers of the gut, then ultimately they result in the perforation. So the mesenteric lymph node, the liver, the spleen, they become hyperemic, they become congested due to the inflammatory response, and usually they have areas of focal necrosis as well, and this all occurs because of the local inflammatory response in that particular system. The mononuclear response may be seen in the bone marrow with areas of focal necrosis. So you see the reticuloendothelial system is primarily involved in the enteric fever and as well as the bone marrow. So these children usually present with the signs symptoms related to the GIT and with related to the bone marrow. Carriers are important, especially in adult group. They are less common in pediatric population, but briefly we have to discuss about it. The propensity to become a carrier follow the epidemiology of the gallbladder disease. and it increases with the patient age and antibiotic resistance of the prevalent strain. The carriage are generally lower in children than adults, as I have already mentioned. And there are 4 types of carriers: convalescent carrier, temporary carrier, chronic fecal carrier, and chronic urinary carrier. Why it is important to know all these types of carriers? Because they are main source of shedding of this organism in the specific um, liquid or body excreta. So convalescent carrier are those which passes the bacilli in the excreta from 3 weeks to 3 months after the clinical cure of typhoid. It means despite cure of enteric fever, these patients have carrier. These patients are carrier of Salmonella typhi, and they excrete the bacilli, the Salmonella typhi organism, in their excreta from 3 weeks to 3 months. The temporary carriers are those which passes the bacilli in the excreta 3 months to 1 year after the clinical cure of typhoid. So temporary carriers are uh, they can shed the organism up to the 1 year. You see how long they are the main source of spreading the infection. Chronic fecal carriers, they continue to pass bacilli intermittently in the excreta at least 1 year after the infection. So what is the difference then temporary carrier and chronic fecal carrier? The chronic fecal carriers are passing their bacilli intermittently in the excreta, while temporary carriers, they passes the excreta continuously from 3 months to 1 year after the clinical cure of typhoid. So this organism can be excreted in the urine. So urinary carriers are those in which the renal pelvis is infected with bacilli, and they pass the organism in the urine. So clinical features are very important to know because when you come into the ward, you come across the many patients with enteric fever, with complications of the enteric fever. So typhoid fever usually manifests as high-grade fever with wide variety of associated symptoms. Associated symptoms are generalized myalgias, anorexia, diarrhea, abdominal pain, and anorexia, diarrhea, abdominal distension. So in children, the diarrhea may be the earlier sign, and it may be followed by constipation. And in the absence of localizing signs, the early stage of disease may be difficult to differentiate from the other endemic diseases. So most common mimicker or most common in close differential diagnosis of the typhoid fever is malaria and dengue fever. So both of these febrile illness also present like this with the fever, the myalgias, anorexia, sometimes diarrhea, vomiting, abdominal pain. So the fever may rise gradually, but the classic step-ladder rise of fever is relatively rare. In approximately 25% of the cases, you can find the rose spots on examination, which usually visible around the 7th to 10th